I think great progress has been made on the treatment of newly diagnosed myeloma patients, including the transplant and the non-transplant patients. And in this meeting of the International Myeloma Society, we will have the opportunity to see the update information about the value in Cassiopeia of giving daratumumab bortezomib thalidomide dex followed by daratumumab maintenance. And this is relevant because we have also information in this meeting about the value of daratumumab maintenance. And I think both together, dara plus lenalidomide versus lenalidomide, indicate the value of this combination. Adding more is making more for the majority of the patients. Then this is the first message. The second message is the data for the non-transplant patients. We have heard of the IMRO trial that is comparing VRD, one of the standard of care, versus ISA-VRD in the transplant setting, in the non-transplant setting. This was also presented at IHA with very robust benefit for the quadruplet combination. But in this meeting, we are going to have also the opportunity to see the CEPHEUS trial that is compared VRD versus dara-VRD. And almost the same comparison. The only thing that changed is the monoclonal antibody, daratumumab or isatuximab, but both against CD38. And both afford a hazard ratio benefit about 43%, 42% benefit for progression-free for patients receiving the quadruplet. In other words, the hazard ratio is 0.57 in the CEPHEUS that is going to be presented, and it was, I think, 0.59 in the IMRO trial. Another interesting update is also a trial conducted by the French group that is called the BENEFIT trial. And this trial focused on the benefit of adding bortezomib to a combination of anti-CD38 plus lenalidomide and dexamethasone. And for me, it was a surprise because yes, bortezomib is making a big difference in terms of the MRD rate. That in the benefit, the MRD rate at 18 months increased from 26% without bortezomib to 56% on patients receiving bortezomib. Therefore, I think all these data speak in favor of these quadruplets in which you can combine all these. Also, the MIRAS trial is going to be presented that is using in induction ISA-KRD. And then they will adapt according to MRD. With 6 cycles of ISA-KRD, the MRD rate is 62%, the highest that we have seen in induction. This reinforced this idea proposed a long time ago by the Spanish group that probably in sensitive patients, 6 cycles could be very good for the patients. These are some of the most relevant trials that I think are going to be presented.